Our presentation will be starting in just a few moments. If you are in this webinar, I hope you are here to listen to Dr. Sheilah Robertson discuss navigating anesthetic drug shortages after COVID-19. My name is Dr. Sarah Kirk. I'm adjunct faculty with the Maddie Shelter Medicine program, and it is truly an honor for me to introduce Dr. Sheilah Robertson. I feel that with this Florida audience, she likely does not need introduction because you've had the benefit of her instruction for many years, whether that's as a student at UF or participation in Operation Catnip or simply by attending shelter medicine lectures as I did. And I have to say with all honesty that she has always been one of my favorite speakers. She is an anesthesiologist and pain management specialist, and she is going to enlighten us as to how we can continue to practice shelter medicine during this time when anesthetic drugs are becoming scarce, are the ones we turn to, or have the potential for shortages coming in the near future. So, Dr. Robertson, please.
So thank you very much for that introduction, Dr. Kirk, Sarah. Yeah, I'm always happy to do anything I can to help anyone in the shelter world, and of course have never regretted doing my shelter medicine certificate through UF Maddie's. It was a wonderful experience. So I'm going to talk about navigating anesthetic drug shortages or potential drug shortages that are currently showing up and are going to probably continue to show up. Although I will warn you that it's pretty much an unknown, but I like to practice, you know, the philosophy of always being prepared in case something is going to happen in the future. So what I am going to do is I am going to walk us through, oh, hang on, we've got just the typical, there we go. Let me just make sure we're, yeah. So these are my discussion points. So I think to understand why we are already getting into a supply shortage of certain drugs and why the demand has gone up for drugs that we compete with the human physicians. I'm going to talk about why that's happening, because once you understand why we have a problem, you're much more able to sort of be less irritated by it because you understand, you know, who else is in trouble with this drug shortage. I'm going to explain a little bit about the global supply chain, and I think what we are going to learn during this COVID pandemic is that global supply chains are very, very fragile and dependent on, you know, certain parts of the world, and that is clearly going to have to change. I'm going to talk about which drugs might be affected by the COVID pandemic. And then most importantly, I'm going to talk about solutions so that we can pivot and keep doing the life-saving work that we already do and must continue to do related to shelters. So I think to understand the sort of just the magnitude of what has happened since early this year, since January in 2020 in the United States, you know, we started hearing about COVID-19 and that people were getting respiratory illness and going into hospital. So you kind of think of like one person going in and ending up being on a ventilator. But the magnitude of it, I think you have to start thinking. So here is actually inside a COVID unit in New York, and you can see obviously, you know, exceptional PPE, but this is just a corner of one of multiple COVID hospital wards throughout America, but then think about throughout the world, and then think about South America at the moment, who are just behind us on the curve, and they're escalating in this sort of scenario. So we look there, and that looks like a very busy place to be. But then we kind of look at the hospitals that were built to deal with this pandemic, and this is one of the Nightingale hospitals that was built in the United Kingdom, and able to ramp up and deal with these sick people on ventilators or not. And then you look at the size, and so it's not, we're just not talking about one person on a ventilator. We're talking about thousands and thousands of people globally requiring to go on a ventilator to battle this disease. And then if we go back to that person on a ventilator and we look at the equipment, bedside to them, this is, probably minimal amount of equipment that is next to their bedside. And you'll all recognize these infusion pumps. So talking to human anesthesiologists who are being recruited into COVID units because they're good at intubating and getting people on ventilators, they're telling me that some of these patients are on 50 different drugs throughout their stay. And a lot of them are to do with anesthesia, sedation, and pain management. So if we look at the drugs that our human healthcare frontline workers are using at the moment on these patients, they're using dexmedetomidine, and a lot of people will be surprised to know that that is one of the #1 drugs used in humans in order to get a person ventilated or kept quiet. And usually they only use it for 24 hours. Now they're learning to use it for weeks on end. They're starting to use ketamine. They use propofol as infusions, and they use a lot of midazolam to try and keep these people sedated and on the ventilator. The other drugs that they have to use for pain and agitation are fentanyl, which some of us use, not so much in shelter medicine, but hydromorphone, a lot of us use, and morphine as well. And these drugs are being used to help do multimodal care of these patients. But it's not just the anesthesia and the analgesia and agitation that these doctors and nurses and healthcare workers are dealing with. There's all the other parts of being on a ventilator. So the gastrointestinal issues. So things like famotidine, which we'll talk about, since it's very, very difficult to get right now. And then for respiratory control, because it's a respiratory disease, albuterol and some of the steroids that are used to help with inflammation in the lungs, cardiovascular drugs, because these people go into shock, a lot of blood clots, you've probably been hearing about that, so heparin. And then of course, covering all of that as an umbrella is infection control. So external with chlorhexidine, but actually secondary, like antibiotics to cover these people for secondary bacterial infections. And so all of this comes back to like, these drugs are all in huge demand at the moment. And then if you think about the other things involved with looking after these people, their eyes need to be looked after, like, eye lube, but we're talking like for days and weeks on end, not just like we normally do, one drop of eye lube or something to get through one procedure. And then the diluents, the small bags of saline and the bottles of water to mix up drugs, these are now becoming quite tricky to get. And then we're going back to our IV fluid shortage, which we dealt with because of the Puerto Rico hurricanes, earthquake, and so on. But IV fluids, or specific IV fluids, may be in shortage again because of the increased demand. So I love this quote from this doctor who has an MPH as well. So Asaf Bitton, he said, living in a science experiment can be messy. And that's what he feels we're currently living in, but we're having to like pivot as we go through this science experiment called COVID-19. So the drugs that we share with the human physicians, and so these are the drugs that are used in both species. And again, I think a lot of you are probably surprised about dexmedetomidine being a human drug. They have their own product, which is labeled for them, and we have our product, which is labeled for use in dogs and cats. We use propofol, and they use propofol, and we do have our veterinary labeled propofol. A lot of you might use propofol 28, but they have propofol. Ketamine is common between both of us. Etomidate is common. And then diazepam and midazolam are human drugs, and there is no veterinary formulation of these. So, you know, if they're in high demand, then we clearly get put at the end of the list to get them when there's a huge demand for human use. And then the analgesic drugs that we share as well are fentanyl, morphine, hydromorphone, butorphanol, even though we do have our own veterinary products, and buprenex or buprenorphine. We do have some veterinary specific products that will not be affected by the demand in humans, but butorphanol and buprenorphine are not in high demand at all for dealing with these COVID patients. So these are drugs that we aren't that concerned about, but the others I am quite cautious about. What am I going to do if we run into shortage of all the other drugs I've mentioned? So just again, to comprehend the demand and supply, this is data from March, only in March, when New York was at its peak of the crisis. So this is the increase in demand. So this is the increase in the number of prescriptions that were coming from the COVID wards to the pharmacy for certain drugs. And the ones that kind of hit you right there is the requests from the doctors and nurses on the front line for midazolam went up over 4,000%, right? I mean, that's just mind-boggling to me. And albuterol, you can see over 1,000% increase in demand, fentanyl, propofol, and then norepinephrine. So clearly, unless there's a huge amount of drug in stock to meet that demand, the system falls apart. So what happened was, as the demand surged, about 50% of prescriptions went unfilled, but they still had to nurse these patients. So, you know, they had to come up with solutions. And, you know, this kind of brings us to what I want to talk about before I go into, you know, what some of the solutions are, what they did, and what we are doing and what we're going to do to get through this, is talk about the global supply chain. So we are very globalized now, and we're very interdependent between countries for product, whether it's, you know, raw compound, finished product. And we're talking about food, and we're also talking about drugs and everything that we use in life. There's this global supply chain. So just to explain how crazy this gets, and to use an animal to explain it, we're going to talk about giant pandas just for a moment. So giant pandas, as you all know, are like the cutest things on earth. And they have luckily been shared by China into a lot of our zoos and Canadian zoos. But the only thing they eat is fresh bamboo. And if anyone wants to hazard a guess about how much bamboo one giant panda consumes in a day, you can, but I'm going to tell you, it's 45 kilos. So we're talking over 100 pounds. So that's a lot of fiber. So that means a lot of panda poop too. But this is all that they eat. And so this is what they're dependent on. And there are two giant pandas, Calgary Zoo. And right before COVID, the way they got their bamboo was a flight came from Beijing once a week, full of fresh bamboo in the cargo hold. They stored it, they fed it to the pandas. And then obviously with COVID shut down, those flights ceased. And there's only one place in Canada, and of course, remember, this is still was winter, and that was Vancouver Island, that grew any bamboo. So there was a real shortage of bamboo. So one of the results of the coronavirus is that the Canadian Zoo is working, they're struggling through it right now, but they are going to return the pandas to China because they can't, with the global supply chain interruption, get the bamboo into Canada. So this shows you how dependent, and if we don't have a backup plan, when we've got to pivot. And this is one great example of why we're having problems. So what about drugs made in the USA? Almost none. There's very, very few drugs. There's one out of the top 20 drugs that are required right now that is made in the USA, and overall, less than about 15% of all medical drugs are actually made in the United States. So we are dependent on importation and other countries for our drug supply. And the drug supply, again, it's the global chain. So pretty much all of the active pharmaceutical ingredients, so the raw ingredients that go into drugs, are all sourced or are in China. And so they actually provide the raw ingredients for nearly every drug in the world. And they actually make a lot of the drugs in the world, and then they're exported. So if you think about that supply chain, raw pharmaceutical drug or drug made in China often or can often go to India for the next step, or go to some European countries. And very rarely does it come to America to then be made into a drug. So we've got shipping, we've got flights, we've got road transport. So we've got everything from the raw drug going through all of this chain and supply, and being checked for purity and all the other things that go into the drug, and then arriving at the hospital to be given to the patient. And so just for example, propofol, this whole process takes 30 days. So even if an answer was to ramp up production and we didn't have a disruption in supply chain, there's still a lag before we get product back for use. So this is how complex this whole thing, I mean, it's really shown us where the problems are with a lot of supply and demand. So a lot of you know how to use a QR code. So if you're watching this and you have your smartphone, if you hold your smartphone up to that black and white box, the QR code, that's going to take you straight to a website. And I'm going to PDF this talk and make sure it's available for you, so you don't have to rush and write this all down or do it right now. But this is a new resource that has been set up by FDA, where you can go and check on what drugs are in shortage, why they're in shortage, and then they actually have information about what's being done or when they think the shortage will be resolved. So it's a very, very good website for checking on what's going on at the moment. So the interventions that they're making to mitigate these current or potential shortages are to ramp up production, but there's a delay in that, big delay in that. And I have just been told recently that plentiful supply of midazolam is probably not going to happen until next year, 2021. There's been an extension of some of the use-by dates. I'll talk about that. For some drugs, they're increasing importation quotas into the US and actually changing some of the strict policies for compounding of certain drugs. And a lot of us in shelters do actually order drugs for in-clinic use from compounding pharmacies. So we were already dealing with the opioid crisis, and the response to the opioid epidemic and addiction in the US had been to decrease the production of specific opioids and their importation into the US. And that started in 2017. And it affected hydromorphone, morphine, and fentanyl. And we dealt with all of that. So what they've actually done because of COVID is that these imposed quotas are being relaxed. So these drugs are probably going to be more available on the human side, and maybe eventually again for us. That's a bit of an unknown, and I'm not going to depend on those drugs at the moment. So the FDA is alerting health professionals of products that they may have in their pharmacies or stocked that can be used beyond their expiration date. And again, this is the QR code to take you directly to that website. And it's just for very, very specific drugs. And you may or may not have these drugs on your shelf. But if you've got something on your shelf that's about to expire, go to this website and I'll show you what it looks like. So this is just some of the drugs that are on the website. So midazolam is there, lidocaine, which is actually it's difficult to source, and bupivacaine, albuterol is on this list. And what they've done is they've looked at the product, preservative, and so on. And for some of them, and I'll show you just like that, looking at what they've is in the bottle, they've actually extended some of these use by dates by over a year. So as long as you have the right NDC number, the lot number, and if yours says it's going to expire July 2020, you don't need to do anything except document that you checked that you're okay to use that till 2021. If you were inspected, you can do that. But it's not every drug that you would have on your shelf, but some of them. And some can't be extended. So it's kind of like, I will, without thinking twice, will use expired spices and dried pasta in my pantry, but I'm not going to use expired salad product that's 10 days over its best use by date. So it depends on how the drug is, what preservative is in it, and so on. So if we talk, the AVMA have said, I think the best description is they are concerned that there are going to be shortages coming up, and they're tracking it very carefully. So they said they are concerned, and they're keeping us up to date. So they have been interviewing and working with 32 animal drug companies that make drugs or source active pharmaceuticals in China for the US market. So that's for us. And from those interviews and contacts, what they have found is that 20% of these veterinary drug companies do see a disruption in the supply chain coming up that could lead to shortages. Now, we don't know which companies these are and which drugs specifically that they're talking about, but they've been identified. And we can kind of guess what they might be, and AVMA is keeping us up to date. So AVMA, again, you can scan this. I just checked this website yesterday, and they updated it on May the 22nd. So this is a AVMA website that is not closed to AVMA to the public. It's you don't have to be an AVMA member to access this site. And they are looking at and updating it. And what I just saw yesterday was, at the moment, on back order are quite a large list of antibiotics that we use, alprazolam tablets, a lot of ophthalmic preparations, and it makes sense to me because of all the eye care going on with human patients. And the one thing that is back ordered right now is famotidine, because it's being used obviously for these people on ventilators. And so if you go to that website, there's a long list of what's on back order at the moment, and the AVMA is keeping that updated. So I would probably bookmark that on your website browser, bookmark that. The other thing is, we, luckily in the US, can go to compounding. So for in-clinic use, we can go to compounding, but remember, it's state by state, and I know I'm talking to the Florida group right now, but don't forget to follow all the rules about compounding so as not to get into trouble. And I haven't heard whether or not there will be relaxation of some of those rules around compounding, but clearly that's a possibility to help us through some of the shortages. So if we're thinking about, we were in quarantine, we were stay at home, we were in lockdown, but now we're easing restrictions and we're all moving into elective surgeries happening again. And we're in that massive catch up kind of period. So we're getting busier about our elective surgeries. So that means we need more drugs. So this is the good old days, right? When there was a choice of everything and lots of it on the shelf. Because I'm using toilet rolls, because it seems to be the thing that got affected by COVID. So we used to be able to choose, hey, what do we want for our anesthetic protocols? Let's choose, all of these different things, and there's lots of them. So that's the good old days. And the good old days, we aren't going to see them for a while. So right now, we have these two situations. We have the shortages or back order, or we have what's called on allocation. So some veterinary drug companies, and one of them is Zoetis, have put people on allocation for certain drugs. And one is propofol, one is dexmedetomidine. Now that doesn't necessarily mean that they are in short supply, but they're putting you on allocation just as supermarkets allow you one package of toilet paper. And this is to stop people hoarding, because we want to share so that everyone can do what they need to do. So that is why some of you may have found that you're on allocation. So what COVID-19 hospitals did was, when things couldn't, like 50% of their requests couldn't be filled, they reached for alternatives. So they looked for the next available drug on the list. And sometimes they were like going down the list going, ooh, what's our substitute here? And the problem is that our familiarity with each change decreases. And what does that do? It increases risk, because we're not familiar with a protocol or with a drug. And certainly that is not ideal. In one hospital, a doctor was on a webinar and said, yeah, our hospital had to pivot to using ketamine. And we did on-the-fly education in 24 hours on how to use ketamine on these patients. And we don't want to be in that situation. We want to predict it, plan for it, and not have a problem. So this is what I figured out at the moment, where we are as veterinarians right now and potentially down the road. So from some VIN questionnaires and my own online questioning of anesthesia diplomates, what I've found is like about 40% of people are having trouble sourcing their normal anesthetic protocol drugs. And a lot of them are now having to order from multiple distributors, and that, adds, frustration and time, and, practice managers are having to, order from places that they don't have a contract set up with, and all that type of stuff. So at the moment, midazolam is almost impossible to get. Propofol and dexmedetomidine are on allocation, and then a lot of the opioids are either not available to us, for example, hydromorphone, very difficult, or they're on allocation. Now, this is not consistent throughout the country, but it's a general consensus that these are either allocated and you're not going to get much, or they're not available. Ketamine we're starting to see shortages. I had a large animal veterinarian in the Northwest call me and say that they were now having problems getting ketamine, and lidocaine and bupivacaine for local blocks. Those are in shortage. And we have no veterinary substitute for that, for the regular lidocaine and bupivacaine, for doing any local blocks that we would do related to spays and neuters. But there's one thing that veterinarians and veterinary technicians and nurses are, and people that work in shelters, and they're MacGyvers. And actually the word MacGyver is in the Oxford English Dictionary. It's actually as a verb. It's actually in the dictionary. And I think it fits the veterinary profession really well, that we are amazing at improvising and inventing ways to do things using whatever we've got at hand. So MacGyvering is something we're good at, luckily, in this COVID-19 crisis. So basically what we need to look at is, what do these nurses and technicians and who are anesthetizing this dog, what do they need to produce anesthesia and all the components that are important to anesthesia to allow the surgeon on the left there to deal with this? Yep, that is a pyometra, one of the biggest ones I've ever seen in a dog. But what do they need to put into the anesthetic protocol for us to be able to do this surgery safely? So we just break down the components of anesthesia, and this is what it is. We need the patient usually to be unconscious for doing an abdominal procedure. For a lot of our things, they could be highly sedated and with a local anesthetic for some minor procedures, but usually we need them unconscious. We'd like them not to remember the episode at all. So amnesia. They do need analgesia. They need to be nicely relaxed, and we would like them to be pretty stable under anesthesia as far as heart rate, blood pressure, and so on. So how do we normally create, and how do we create a good anesthetic that contributes or actually supplies all of these things that makes, the work of the surgeon easy, or easier than it would be without one of these components. So just to take an example of what a lot of shelters would use and a lot of GPs would use would be to take these healthy, boisterous dogs that need spayed or castrated, dexmedetomidine and an opioid of your choice. They would induce with propofol or with ketamine and a benzo, which would be either midazolam or diazepam. Pop, depending on how long it's going to take, pop a tube in, keep them asleep on an inhalant, and they're going to get a non-steroidal for analgesia as well. But with the crisis that we've been talking about, what it could look like is that's what you have on your shelf. A lot of things have disappeared. We probably are still going to have, our veterinary opioids, the butorphanols and the buprenorphines. Isoflurane and sevoflurane, there is no danger of shortage with them that we can tell or even envisage, because none of the people on the ventilators are actually under anesthesia with inhalants. And the non-steroidals are very, very specific to dogs and cats. We're not sharing non-steroidals with humans. We don't use the same ones. So we don't think we're going to have a problem there. And then we have our kitty magics that we all love, and there's so many different ones, but common one is dexmedetomidine, ketamine with our opioids. We use that all the time, but again, we may be losing some of the components of our so-called kitty magic. So what do we have that we don't need to worry about? And what should we start looking at and getting comfortable with? Well, that is acepromazine. Certainly, there's going to be no shortage of that, no competition with humans. And for some of our well-behaved, nice dogs and cats, acepromazine is a good tranquilizer. Now, the other thing is, if dexmedetomidine becomes in short supply, we can switch to medetomidine, which is what we used to use. And then we can use xylazine for some procedures. I would prefer medetomidine over xylazine, but we'll talk about, when we could use xylazine to preserve our supply of dexmedetomidine or metomidine. Thalidomide and zolazepam, there is no human equivalent of that. And so we're going to be okay with that. And then we have Alfaxalone, which a lot of you probably haven't used in shelters, but certainly I'm working with the company Durox to look at its cost effectiveness in shelter medicine. And actually it's not as out of your reach as you would think. So we're not, and there's no human equivalent. And then propofol and ketamine, we do have our veterinary products, but the raw ingredients may be funneled down the human chain to keep human physicians supplied with propofol and ketamine for their patients. So we need to think about potentially losing those. So for analgesics, I said the non-steroidals are pretty rock solid safe at the moment, although someone asked me why carprofen, certain generic carprofen is on back order, but butorphanol should be safe. Buprenorphine, buprenorphine SR, which is the one a lot of us source is compounded, that is still going to be available. And then Simbadol, which is for cats only, it's the one injection that lasts 24 hours, that isn't going to be a problem either. Potentially, and we don't know where every drug company gets their raw ingredients, potentially if everything stalls in China or there's embargoes, some of these things could potentially be affected, but they're way down my list of concern. The other thing I think we need to start thinking about is doing a lot more oral sedation with our patients before surgery. So we all know gabapentin's great for cats, for making them chill out, easier to deal with, trazodone for dogs, and then there's some good studies in humans and now in veterinary medicine that fairly high doses of melatonin, and I can include that in the resources, can actually help with sedation. And if we have these drugs on board, what we find is the animals, I guess its brain chemistry is in a much better shape not to fight anesthesia. When an animal is extremely stressed, we know it takes a lot more to sedate them and a lot more to get them intubated. By pre-sedating them, by oral sedation with these drugs, we know we're going to use less pre-meds and less induction agent. So that is good for the animal as far as welfare, but also good for being anesthetic saving. So what you're going to do, or what you've already done, because I know how smart shelter veterinarians are, is that you're going to make a plan. So you decide, you know, what might you no longer have access to, and what alternatives should we order and start practicing with, and have them on our shelf. So we don't have to say, guess what, next week's elective list for spays and neuters is on hold. And then of course, then your adoptions are on hold. Think about how you can conserve specific drugs for very specific needs. So if you still have a little bit of midazolam, you want to not use that for your big healthy routines. You want to save that for your geriatric dentals. If you're doing them in your shelter, that's what I would suggest. You need to have training sessions for your team using any new protocol, because you need to like ramp up, and we're going to be busy, and we don't want, you know, anyone falling through the cracks and not understanding how the new drugs or the new protocols are working. So that's continuing education. And again, consulting with people that have pivoted to, you know, switching their protocols. You know, how did it go? How did you introduce it? How did, you know, what did you like or not like? So consulting is a good idea. So the reason I'm bringing up, like, do it now before we have a shortage is airline pilots never want to even think that they're going to, you know, stall or have birds go in their, you know, into their engine. But what they do is they practice for every imaginable thing that could go wrong with an airplane in a very controlled environment. And if they don't get it right, they can bail, they can pivot, they can go back, you know, to what they were doing. But we don't want to suddenly show up on a Monday and all we have is a drug that we're not familiar with. And we're like, oh, that's going to be tricky. And the reason that we want to practice for potential problems is we will be successful. I mean, do you think Sully didn't practice in the simulator for birds going into his engine? Of course he did. Never thought it would happen, but it did. And it all turned out, you know, like a miracle, as it says. So we are going to be agile, pivot, plan, and train for this new world that we are entering. So the team, and that means everybody that works in the perioperative area. And remember, you know, the team leader or the surgeon may not be the person that has the best idea about how to pivot. I certainly would step back and listen to the nurses and technicians and so on about how they think we should do this. So the team is going to meet, decide, okay, if we're, you know, so comfortable using, say, propofol, and we're not going to have it, what are we going to use instead? And we better start practicing. And you want to have some dry runs while you still have your, you know, comfort level with being able to fall back onto your routine protocol that you're currently using. So plan, you know, for this change to happen. So the one drug that a lot of you may find that you are going to take another look at is Alfaxalone. So Alfaxalone is made by Durox, and they're an Australian-based family-owned company. And the original problem with Alfaxalone was once you opened the bottle, it had to be used that day. And people were like, not going to do it, that's such a waste. They've actually just increased the shelf. Like once you broach the bottle, you can now use it for 56 days. So even if you only use it occasionally and you have it on your shelf, it's good for 56 days after you broach the bottle. So that's new information. It was 28, now it's 56 days. They've also brought out a new product called Alfaxan multi-dose IDX. So if you are in a shelter that does some like strange creatures sometimes, like birds and reptiles and rats and stuff, this is a product that is used for all of those creatures, and they have great information. I mean, there's almost nothing, including you know, the strangest bird or even a blue crab. They have a anesthetic protocol for blue crabs, but it's been used in Florida flamingos. So it's a very good drug to have for that reason. So the problem at the moment is that it doesn't have a big market share in the US, but in other countries, it's got a huge market share. So I have got data showing that about 30% of people in the US have never used this drug as an anesthetic. About 20% have it, but aren't very comfortable or don't use it very often. So that's about half of the people are very unfamiliar with this drug. So it's about time to probably think about getting some in and having it in supply. So Durocs are very, very forward thinking about educating us on anesthesia. So they have this Think Anesthesia website, very non-commercial. It's got great webinars on it. You just sign up, it's RACE approved, and the CE credits are free, which is amazing coming from Durocs. They've got great webinars. And the ones that I would suggest you look at if you're going to pivot to having some Alfaxalone available would be these two. And they're adding more each week right now because they realize that people are having to switch some of their protocols. They have one on using Alfaxalone for dentals. So anyway, certainly that website is worth checking out. The other thing is if dexmedetomidine, if you've got used to that, then we might want to think about ordering in some medetomidine. Now, that's what we used to have prior to dexmedetomidine coming out. And it's very, very similar drug. And in some countries, that's what they have, that or dexmedetomidine. But in the USA, what they did was once dexmedetomidine came on the market, medetomidine disappeared. But it is actually still available. People just didn't go looking for it. So you can get it. It's a generic from Modern Veterinary Therapeutics. And the US distributors are listed here. And again, I'll make sure this goes into the resources. It is less expensive than dexmedetomidine, but very, very similar. And the volumes that you would use are identical. They've made it like, because of the strength, the volume that you use is identical to dexmedetomidine. So this might be something worth getting some of it on your shelf in case there's a problem with dexmedetomidine. So if things got really bad and ketamine disappears and propofol disappears and dexmedetomidine and ketamine, you know, all those things happen, you know, I can still get this little angry cat under control with medetomidine, some Alfaxalone, and some butorphanol, which we will have. And these are just, you know, I've just put up a protocol that I would tend to use. And this would get this little guy under control with an IM injection, would get him under control within about 5 minutes. So it's not a complete substitute for Kitty Magic, but Alfaxalone can substitute for ketamine. And there's good shelter protocols from Canada where they compare doing cat neuters with Alfaxalone instead of ketamine in their injectable mix. And actually there were some advantages. The cats ate sooner, had good, you know, recoveries were fine, and so on. So this is just something that you could pivot to if we go down the road of shortages. So this is actually a video of a cat getting a very, very similar protocol. He is in a squeeze cage. A lot of us are used to the feral cat cages. This was at one of our clinics when I was up in Michigan, and the student hasn't used this technique or this cage, but she does actually get the drug into the kitty, and she doesn't get hurt. And then 5 minutes later with that protocol, we have a cat that's not necessarily ready for a castration, but a cat that is very easy and safely handled. So I know there's a lot going on with ASPCA, Best Friends, and Maddie's, getting everybody ready for, you know, boom, we're going to be busy. And I actually went and downloaded the guide. If you don't already have this guide, it is fabulous. It has a lot of anesthetic ideas, similar to what I've been talking about. It's got preparedness guide, you know, we're ramping up, but it's not going to be the same as it was. So again, I'll make sure you get that QR code if you haven't already downloaded that. Premixes, the one that we're very, very familiar with using in probably dogs and cats is, you know, the sort of tyletamine, zolazepam, so the tilazole mixed with butorphanol or buprenorphine and dexmedetomidine. And we all know, you know, everyone calls it TTD. We can get mild sedation all the way to general anesthesia with that mix. But again, we can switch that out to medetomidine if we need to. And I just went through a protocol substituting the dexmedetomidine with medetomidine for cats. So this is actually in the preparedness guide that I just showed you, and it's super easy to mix it up. The volumes all match up with your old dexmedetomidine volumes, and this is the concentration, and these are the doses. So it's small volume, given IM. It's really good for cats, but we're just switching out dexmedetomidine for medetomidine. And then and you can actually download the concentrations, so you can do your, remember your controlled drug logs. Your tyletamine and your butorphanol would have to be logged, so you can do that. The other thing is conserving drugs. And one of the ways I've been coaching GPs to conserve drugs is changing up their pre-euthanasia sedation. So instead of using their normal pre-anesthetic sedation protocols, I've been persuading them to switch to a lot of protocols that we use at Lap of Love, which is, you know, in-home euthanasia company that I work with, and conserving drugs. So we use a lot of xylazine and acepromazine in our pre-euthanasia sedation for dogs. We've got protocols for cats, and that would preserve the dexmedetomidine and metomidine and save money as well. So there's a lot of options. And the other thing is, when there's time, it's really nice to give these animals oral sedation. So the cat's gabapentin or the dog's trazodone prior to their euthanasia. That makes things a lot easier for them, a lot nicer for them and for us. But again, there's no need to use your precious dexmedetomidine to sedate an animal for euthanasia when you can use an alternative like this. And so this is Lap of Love's resources here. If you use the password DVM support, you can go in and get all of our protocols, you know, using drugs that are currently available. The only pivot we've had to do at Lap of Love with euthanasias is we are not able to source any midazolam, so that's not in our protocols at the moment. So we are very good in shelter world about pivoting and learning to adapt. We've all learned to adapt. Well, we already knew how to wear a mask, right? The general public didn't. We know how to stay a meter apart. And I'm going to show you one picture that to me depicts, like, you know, how hard can it be, right? These cats, that is an internet picture. These cats saw the little circles and decided that they must mean something. So they're outside this food store and they have just automatically adapted to the new rules in order to get their treat from this vendor that runs this little street store. So we can learn to adapt, and we're going to be fine, but we need to prepare for not having some of our familiar drugs, I think. So Sarah, I don't know if that went through well and clear. It was a lot of information, but again, I am going to make this presentation available as a PDF, so you'll get all the QR codes and the things that I had up on the slides. And if we have time, and I'm very happy to stay, I can maybe take some questions.
Sheila, that was wonderful. Thank you so much. We do have a question. When using the medetomidine, Alfaxalone, and Torb sedation, do cats need a mask or for spay-neuter surgery?
Yeah, so it's going to depend. So I had 1 or 2 milligrams of per kilo of Alfaxalone in that protocol. So the problem, so Alfaxalone given IM, it's off-label at the moment in the US, but you know, you use everything off-label, so that doesn't stop us doing it. The problem at the moment is the anesthetic dose of Alfaxalone given IM is 5 milligrams per kilo. So the volume is, you know, not doable really. So what we've been playing around with is adding, you know, an alpha-2 and an opioid to decrease the volume that we need to give of the Alfaxalone. So these animals will be, if it was a big tomcat and they were pretty out of it, I would probably, if we had lidocaine, I would do a block into his testicles and probably I could castrate him. But you may need to give some gas anesthesia, isoflurane or sevoflurane. The other thing that's being looked at down the road is, because Alfaxalone is so versatile in every species, you know, piglets, I mean, everything. The wildlife people use it a lot, but again, this volume, because it's a 1% solution, which is 10 mg per mil, the volumes get like totally unwieldy. But I've just been reading through some wildlife abstracts, and they've been testing out a 4% solution in the wildlife arena. So clearly there's moves in the works, I guess, to make up more concentrated solutions. But I don't know when and if that's going to come to market. But, you know, you cannot get, you know, 0.5 mg per kilo for the anesthetic dose isn't really doable. So that's why we lower the dose and then add a sedative and an opioid to it. So we get an animal that's very much under control and may or may not require some gas anesthetic. So it's kind of a, it depends is my answer.
And continuing with that combination, the question has been raised, can you switch out Torb, or can you switch out buprenorphine for the Torb in that mixture?
Absolutely, and it's depending on what solution you're using, you'd have to obviously do the math, but absolutely. And for, you know, a lot of times I will use buprenorphine with that. And a lot of people, you know, I talk to people about their protocols, and a lot of people start with, you know, butorphanol in the mix because we do know we get good sedation with it, and then give a dose of buprenorphine afterwards. So butorphanol at the beginning and then buprenorphine. If you want to get good, you know, good analgesic coverage for more than, you know, an hour, I would put substitute buprenorphine into that mix. And then people always say to me, but oh, I've heard that buprenorphine takes a long time to kick in and so on. And, you know, that's actually not totally true. So it starts to work within 10 minutes of giving it. So as the animal's sedating, it is starting to provide analgesia. And then buprenorphine's peak effect is within about an hour. So that's when a lot of animals are, you know, recovering from their anesthesia. Well, we all know that you guys do castrations in a minute and spays in 7 minutes in cats, but they're actually going to get the peak effect of the buprenorphine when they need it. So yes, you could definitely go ahead and substitute the buprenorphine for the butorphanol. But what you want to do is you want to start practicing some of these right now with maybe very cats that are very willing to work with you to see what you get, so that you know what you're going to get when you are maybe pushed into the situation where you have no choice. But then you're not going into it like, I've never done this before. Like these poor doctors on the front lines that have to learn how to use ketamine in a 24-hour period. Suddenly they're, you know, anesthetizing people and doing things with a drug they've never used. So we can be ahead of the game and be, you know, really ready for this. And you know, I work, some people will call me a pessimist for, you know, doing these type of seminars, but I'd rather prepare for the worst, but maybe the best would happen. But what if the worst happens and we do have a shortage of these drugs? I think we should plan.
I agree with you, and I think our audience would agree as well.
Yeah.
And
we know what happened, you know, when we had the hurricane and then the earthquake in Puerto Rico. Remember, Puerto Rico is one of our big sources of IV fluids, and we all went through we can't get IV fluids. And then that's where the Ethicon factory is, right? So then there was the suture issue as well. So, you know, with this, you know, we kind of see how it's going, and we kind of know that, you know, the way the virus is behaving, that there could be a second wave, and so the shortages are going to continue, and the demand for humans is going to continue too. We wish that wasn't true, but we need to assume it will be.
right. We have another question. Would just Telazol and Bup be an acceptable protocol for cats IM?
Yes. Yeah. So you've got your anesthetic, your thalidomide, you've got your muscle, you know, nice muscle relaxation with your zolazepam, and the ketamine does actually provide some analgesia. And then you have your opioid. Now, if you were doing a spay, I would prefer that you use buprenorphine. You know, I think a castration, butorphanol, you know, is fine. But remember, if you do have some local anesthetic, like you have either bupivacaine or lidocaine in your shelter, then you can, for the spays, you can drop buprenorphine into the abdomen. And there's now 2 papers out showing for spays that doing the block on the cervix and at the 2 pedicles. One was done in a very controlled environment to actually establish the actual protocol. And then a very large shelter in Texas did that block. They call it intraperitoneal, but it's actually a block that they do for spaying cats. They showed that it was very cost effective and very easy to do in a high volume spay neuter clinic. And I could add that reference, and they have beautiful photographs of how to do it. And I asked them if they could time how long it took to add the local anesthetic block to a cat spay. And they said less than a minute. And then remember, if you're doing pedicle ties, you're saving 2 minutes, right? Instead of suturing. So they said they saw advantages to doing the intraperitoneal local anesthetics, especially in their larger, older cats. I wouldn't do it necessarily do it in a teeny kitten spay, but for older cats, I think it's well worth the time. And it was a very nice paper that came out from a shelter in Texas Hill Country. And I can put that up on a resource list for you.
Great.
And remember, you've still got your non-steroidals, right? You've got your, whatever your meloxicam or whatever, you know, your ONCRs, you know, you've still got those drugs, which we know are, you know, excellent for soft tissue pain. And most of what we're doing electively is soft tissue pain. So the non-steroidals, not controlled, unlikely to be in shortage, and last 24 hours. So that's should be part of your protocol too.
And Sheilah, this is Cinda Crawford. One point you made a recommendation to us to use trazodone. At the time, it was as sort of a pre-euthanasia relaxer before you maybe gave pre-euthanasia sedation. And man, did it work wonders. And I will always incorporate trazodone into, you know, use it in situations that involve euthanasia, because it made such a difference for both the pet and the people handling it.
Yeah.
But, you know, trazodone is not in danger of being in shortage, at least not in the near future. And
No. Yep.
it's cheap. It's pennies
Yeah.
per tablet. And so I would recommend to anyone out there listening to take Sheilah up on her recommendation of incorporating trazodone, at least into your canine pre-anesthesia protocols. It takes, what, 30 minutes, and give it 30 minutes ahead of the scheduled induction time. And you will be amazed at how relaxed the dogs are after that 30 minutes of trazodone on board.
Yeah, it's that's a great endorsement, because I know you used it after I kind of was going, well, what can we use? And you know, it's not likely to be in shortage. It's not controlled. It's inexpensive. And the other thing is, you know, it can be given with a little teeny bit of yummy food, because we know now that these long fasts or absolute fasts that we've been doing prior to spays and neuters really aren't, you know, aren't necessary. So you know, if they, and it's the, and if you use it prior to euthanasia, for me, it's great to see a dog get its last meatball with a bunch of trazodone in it, and then, you know, then you can say goodbye to them. But yeah, using it, I think it alters the brain chemistry that allows them, so they don't fight the anesthetic. There's no doubt that when you're in a rodeo situation, trying to, once that's started, getting them sedated is really difficult, and getting them induced is like they're just like, you go, how much more can I inject to get this dog intubated? But when they come up and they're calm and quiet, it's like a whole different ball game altogether. So A, to conserve drugs, and B, to make everybody's life, including theirs, nicer. That's a great endorsement from Dr. Crawford there.
And it follows or adheres to our fear-free principles.
Yep.
So it's a win-win drug that
Yep.
I don't think is used enough, and provides a multitude, it has a multitude of uses, not just for dogs with fear, anxiety, and stress, or our behavior dogs in the shelter.
Yep. Yeah, and a paper just got published. I just downloaded it actually yesterday, looking at the use of trazodone for helping animals go through transitional stress, I think they call it, as they come into a shelter. And if they were given, this was dogs given trazodone as they came into a shelter, fewer of them got sick, and their length of stay was shortened because of the behavioral change and we assume less stress. I just downloaded that paper yesterday that it helps a lot of dogs with transitional stress when they arrive at a shelter. It's a very nice paper. Again, using something that is inexpensive and easy to use.
Sheilah, a question about puppies and trazodone. Is there an age restriction?
Well, it's not a veterinary drug, and there's almost no studies on it, right? So, I mean, I've used it in, well, I would say I wouldn't know how old they would be. I'm trying to think. I've given it to some, I have given it to puppies, and I would guesstimate, because I remember having to split it, that they may have been about 12 to 14 weeks of age. It was just like in a horribly chaotic environment where the wait time was insane to get, you know, because everybody, it was one of those show up and we will definitely take care of you. And there was puppies, and I mean, so I remember using it. So, you know, like everything, we've got to be a little bit careful because of their metabolism and so on. But I've definitely used it in puppies to calm them down when it was a very chaotic, long wait to get into the clinic. It was on an Indian reservation. We were doing a large clinic. And I'm sure that those pups would have been, you know, 14 weeks old maybe. I mean, I know a lot of you are doing younger than that. but we don't have a lot of data on that because no one's going to do any studies because it's not a veterinary drug.
And would you use trazodone?
I'd be pretty comfortable with it, knowing, you know, what its actions are. Yeah.
And would you use trazodone for feral cats too, or oral gabapentin?
Yeah, so there are some good studies on looking at trazodone in cats, but none of them have shown that it's as good as gabapentin in cats. And if you look at, you know, what I think is one of the best studies done with gabapentin in cats, it was the community cat study, which again, I can put into the notes. And what they were able to do was actually give gabapentin to cats that were already in the trap before they started. And they took the capsules and pulled them apart to get the powder. And then they mixed it up with a very sweet substance. And then they actually put it in a syringe and they gave it to the cats with, I think there's an actual photograph in the paper, which I can post or send you guys to make available. I think it was like a syringe attached to like a tomcat catheter, and they got it into the cats. And it did calm them down, their stress scores went down and so on. And again, if they were, you know, if you were fine about letting them have a little bit, and I am totally fine with putting it in with a little bit of wet food or something pretty yummy and let them eat it, and then they're chilled out, you know. If you've got a whole bunch of cats coming through for spay and neuter, they could have it at income. I mean, right when they come in, they could have, because you want it about an hour and a half to 2 hours, they just chill out on it. And that is fine for them to have it with a little bit of food.
And
Yeah.
I'm assuming the dose is in that paper?
Yeah, the dose that they did, but I usually do it as a dose per cat. So I usually have the 100 milligram capsules. So a regular size cat gets 100, gets one capsule. A really big cat would get maybe 150. And then if you've got much smaller ones, you can go lower, but the side effect that you'll get in these cats is they'll get if you've given a high dose, they'll be a little ataxic and wobbly, but they'll be very, very cooperative and quite sedate usually. And the only thing that would make it have a very, profound effect that would be protracted was if you gave it to a cat with renal disease, because it is a drug that is excreted in the kidneys. But again, what it does cardiovascularly and everything is very, very safe. But if you have a cat that is got pretty advanced renal disease, giving 100 milligrams to that cat, you would get pretty profound sedation and long-acting sedation. But that's not our usual spay and neuter population. Yeah. And then if they do have a prolonged action to it, you just want to make sure that they're kept contained and they can't fall off things, because they are a little ataxic on it. But usually they're pretty chilled out, and most people have really embraced gabapentin. So I think trazodone is great for dogs, and I think gabapentin is better than trazodone for cats.
Wonderful. That seems to be the end of our questions. So I guess my question is for you or Cinda. How are we going to get all of these wonderful resources to our attendees?
Ooh, yeah.
Sheilah's presentation has been recorded, so we'll provide a link to the recording and the PDF copy of her slides, and the other ancillary resources she has mentioned on our Maddie's Shelter Medicine program website, and it probably will be on the very first page that comes up on the website. We may be sending out a link to these resources to the same audience that received the invitation to attend.
Okay, so what I'll do is I'll try and with the thing based on the questions, I'll quickly write down when we end, like what the resources people were asking about, and get them all packaged together and over to Dr. Crawford as soon as I can. And if anyone could, and then one of you can probably sort of like, you know, remind me which ones people were at. If I don't send it, you go, oh, they asked for the other one that you didn't send. Yeah, I'll definitely get all that done and squared away as quickly as possible for everyone to get their game on, so to speak.
Well, thank you so much. This has really been wonderful, and so appreciate your time, as
No,
always.
it's a pleasure. Yeah, we're going to be fine if we plan, pivot, and do our usual MacGyvering. We're going to be fine, but be prepared.
Yes.
Very, very good advice.
Absolutely. I think veterinarians are good at pivoting and being MacGyvers, but maybe a little bit on the short end of the stick for the preparation part.
Yeah, you definitely want to do a try if you're you know, going to change from, you know, something you've used and you're very comfortable with, and you're suddenly going to say, well, you know, I think we should learn how to use Alfaxalone. Yeah, you want to do that. Maybe choose a couple of easy cases and actually do it with the team. And, you know, because there are some, you know, there's a learning curve, and I probably should have mentioned it. One of the things that everyone finds out when they use Alfaxalone, when you use it for very short procedures, the animals are very noise sensitive in recovery. So like, you know, you just something, you know, it should be nice and quiet in your shelter, but that's not possible. And that is something people always talk about, and they're going to go, I hate this, you know, because, and then I remind them, well, do you remember seeing animals paddle a lot the first time you tried propofol? And now we're all like, oh yeah, you know, if they paddle, it's no big deal. It's part of what propofol does. So the noise sensitivity with Alfaxalone is definitely an issue. And then we, you know, but for a longer procedure, it's worn off by the time they wake up, but for some of the castrations. But I can put there's a paper from Calgary where they did cat castrations with a mixture of Alfaxalone and compared it to ketamine, and I can put that in there. I mean, I'll have to make sure what's open source and what's not, but I can get that all in there.
Wonderful. We'll look forward to all of that information, and you have many thanks in the chat box.
Oh, okay, thank you. Well, yeah, I mean, I know how busy everyone is. I don't know how you find the time to look, we have 27 people here.
Yeah. Well, we had more people.
And you guys are super busy. So, yeah.
We had 40 at one point. So.
Excellent.
So, yes. So much appreciated.
Okay.
Thank you, everyone.
Yep. Thank you for hosting me, and I will go and get that stuff put together.
Can you ever get through your list?
No, I've stopped making lists. Yeah. Thanks everyone that's signing off. And I think I can stop my share.
Yeah. Great job. World class, as always.
Yes. Thank you so much.
Thank you.